Hi everyone, welcome to our member briefing today on the Ripple Effect Report, understanding the exposure and impact of suicide in Australia. For those of you who don't know me, I'm Kim Borrowdale, Deputy CEO of Suicide Prevention Australia, and we have Associate Professor Myfanwy Maple from University of New England here, lead researcher, and Michelle Kwan, who is from the SBA team and worked on the research team for the report. Just a couple of housekeeping items. The chat box in the bottom left-hand corner of your screen, if you'd like to put any comments in there or questions along the way, we'll do some Q&A at the end. And the Redback Help Desk number, so if you have any technical problems, give them a call as well, and they'll try and get you sorted out. So, first of all, I just wanted to take a moment to acknowledge the pain that suicide brings when it touches our lives. This report in particular is entirely driven by lived experience. So we've had thousands of people contribute to this report, thanks in part to our members and sector contacts for helping us to distribute that far and wide so that we got a very good response. But I, as I'm sure you do, know only too well the pain of suicide, and I know a lot of us working in this sector also bring personal experiences. So this can be tough going, so as always, if you need to take a break from the webinar, please do, and we do have all of the documents there for you. I think we've put in the chat box, yes, the embargoed report, the media release, and self-care document. So just a personal note to take care. In terms of the lived experiences that have been shared here, we are humbled by just how many people have shared their personal experiences, and we hold that with a lot of respect, and really do take seriously the responsibility of those experiences in terms of how we communicate them and articulate them to people working in suicide prevention, to the public, and to everyone who's working to change prevention for the better. Everyone will have received an advance copy of the report before this meeting, and I just wanted to thank also the network of communications managers who've been brilliant at getting together and helping us to coordinate a cohesive World Suicide Prevention Day and Are You OK Day this week, so thanks so much. So as valued members, we wanted to provide you with an exclusive opportunity to preview the results before they launch tomorrow. The report will be made available from midnight tonight. We've had quite a lot of interest in it already, so that's quite positive. And we wanted to give you a chance to ask, particularly Myf, to any questions that you've got before that goes public tomorrow. I also wanted to quickly acknowledge everyone who contributed to the report from within the sector, the research team, members of the SPA team like Sue Murray, our Chief Exec, and Joe Riley, who aren't with us today. Really appreciated all of the work that's gone into this, and being able to share such valuable contribution to the research pool. So no more from me, thank you, and do get in touch with Redback if you have any problems. I'll hand over to Myf, who will give us a talk through the research and methodology and headline findings.
Okay. Thanks, Kim, and welcome everybody. This is a really exciting opportunity here for Suicide Prevention Australia, as well as for looks like something's going on. As well as for me. Some of you will know I've been working in this field for about 16 years, and so when Sue Murray and I discussed the possibility of doing a survey like this in Australia, of course I jumped at the chance, and I really wanted to recognise the amazing contribution of the over 3,000 people who contributed to this survey, so that we are able to now say some things fairly definitively about exposure and impact of suicide in Australia. So just to start off, I'll give you a quick overview of how we did the survey, and then the headline findings. As Kim said, all of the documents are available to you as members to download now and to share from tomorrow. So The way in which we did this was to use a relatively simple survey that was sent out by Suicide Prevention Australia through the National Coalition for Suicide Prevention and all of their members, so that we could access people in Australia who have been exposed to suicide. So this isn't a representative sample of the whole Australian community. We were specifically targeting people who had been exposed to suicide. In doing that, we also included some standardised measures that we do have representative data for in Australia, so that we were able to say some things about how our sample compares to the Australian population. So to just talk through the demographics of our sample, as you'll see on the slide, our sample was relatively similar in geographic distribution to the Australian population. We were able to increase the number of Aboriginal and Torres Strait Islander participants in this survey, particularly through targeting organisations that work specifically with Aboriginal people. As you'll all be very well aware, our Aboriginal and Torres Strait Islander community is much more affected by suicide, so it was important that we also had a broader understanding of that impact and exposure amongst that community. As happens more frequently than not, our population was more female than male. Women do generally tend to respond to these sorts of surveys more often. And click on there, no. Michelle can make that slide go for me. Thanks, Michelle. As I said, we were particularly targeting people that had been exposed to suicide. So out of our sample, 89% of people had been exposed to at least one suicide attempt, with 85% at least one suicide death. And I think it's important to recognise that 80% of our sample had been exposed to both death and attempt. So being exposed to only a suicide attempt or suicide death was more rare than having experience of both. Obviously, again, we were really targeting this population, and it may be that those reports were on the same person. Interestingly, without us asking people to report whether or not the suicide attempt had been their own, 75% of people did. 75 people did actually report on their own suicide attempt. Obviously, this is a group that we haven't heard very much from in the past in research, so it's a really valuable contribution from those people as well. We asked about the relationship to the person who had died by suicide, and you'll see there a word cloud that has the categories kind of condensed. In reality, the most commonly reported relationships were either friend or brother, and you'll see there a variety of other relationships, including extended family, as well as people outside of that kinship group. One of the things that we had found from previous research in the States is that looking at the relationship closeness was important rather than only kinship. So we included that measure in this survey to ask people both about their kinship to the person who had died, but also about how close they feel to the person who had died. And what you'll see there is that varies across in terms of the percentage breakdown from very close to not close. I think it's important to also recognise that people who didn't feel they had a close relationship to somebody who died also felt motivated to participate in this study. And that's important for us to understand in relation to the impact of suicide on people and the way in which people view this event in their lives. We asked also on a relatively simple 5-point measure how close people, the impacts of the suicide death on people, using exactly the same as what we've used in other samples. So there's an opportunity now for us to be able to do some cross-analyses with other populations. But to ask about whether or not the death had little effect on the person's life, right through to the death had a significant and devastating effect, that I still feel. And you'll see there that by far the majority of people, 37%, feel that the death still has an impact on them, and it was a devastating impact. Interestingly, time doesn't appear to be related to that, and there's some more analyses that needs to be done there so that we can understand for who that longer term impact still exists. As I said earlier, we included a measure so that we were able to compare our sample population to the Australian population. So we use the 2014 National Health Survey data, which is a representative sample of over 12,000 Australians, and that's using the K10 standardised measure for distress. And so what you're seeing in the graph on the right-hand side of the slide there is the Australian population represented in blue and our survey population represented in orange. And so what you'll see there is that generally in Australia, most people experience a low level of distress, with smaller percentages of people having some moderate to high and very high distress. In our survey population, what you see is a much flatter percentage across that group. While still the main group is a low level of distress, what you'll see there is that there is a significant portion of our sample population that are experiencing high or very high distress. Thank you. We're also keen to understand about access to health support services in the 6 months prior to death. Now, this is a little bit methodologically challenging, of course, because we are asking people who were exposed to a suicide death about something they recall retrospectively about the person who is now deceased. So it's not methodologically perfect, but it does give us a bit of a sense of where people were going and what sort of access there was. What's important about this is that people categorically said that no, the person wasn't in any support access in the 6 months prior to their death. 19%, so almost 1 in 5, didn't have any support prior to the death. Of course, many people didn't know as well. We asked about what sorts of supports were being accessed so that we could have a bit of a sense of where we are having good support services being available to people, and you'll see there a lot of people weren't sure, which is fine, as well as GPs and psychiatrists, counsellors, psychologists in mental health units, as well as through hospital emergency departments. As I said earlier, we were able to increase our proportion of Aboriginal respondents to 7%, as opposed to the national population of Aboriginal and Torres Strait Islanders, which is about 2.4%. So we are able to say a bit more about the experience of impact and exposure to suicide amongst this part of our community. And not surprisingly, we did find that Aboriginal and Torres Strait Islanders did know more people who had died by suicide. So an average of 7 people were known to Aboriginal and Torres Strait Islander people who had died by suicide, compared to 3 for non-Indigenous people who responded to our survey. So I'll hand over to Michelle Kwan now, who has been our fantastic support in this research from Suicide Prevention Australia, our Health Promotion Officer.
Hi everyone, thanks for joining today. It's been a real pleasure to be working on this project. I guess a lot of the work that I've been doing is analysing the open text responses from people who wanted to add a little bit extra from the results that they had provided, with the responses they provided, and basically through that process shared a depth of knowledge that isn't quite captured in the numbers. So it basically it was very revealing sort of analysis going through a lot of the qualitative research, but I think from that we've learnt a lot about the resilience that emerges from people who have been touched by suicide. So I'll just go through some of the key themes that really emerged from the qualitative research. A lot of people talked about traumatic experiences. They talked a bit about long-term bereavement that they've felt from knowing someone who's died by suicide. A lot of people also touched on issues of rural and remote access to services, touched on media, health issues, and young people, drug and alcohol. So there was quite a broad range of issues that emerged from the open text responses. Interestingly, over 50% of people actually provided an additional response. So that sort of indicates that a lot of people are actually wanting to share more. We also did some analysis looking at the Aboriginal and Torres Strait Islander group. We found that obviously because we had such a high representation from this group, we thought it would be really good to look further into some of the responses that they were providing. So over 40% of the Indigenous group actually came through and provided more information through the open text. Overwhelmingly, I guess 25% of open text responses referred to multiple exposures, and 20% of people discussed the devastation that referred to a devastating ripple effect that they had that occurred in their communities after a suicide. Interestingly, 25% of people also shared long-term bereavement that they felt themselves, and other significant mentions included 25% of people self-reporting, including some form of trauma that they experienced by the individual who suicided or attempted. So some of the issues that came from that included intergenerational trauma, family issues, domestic violence, and drug and alcohol use as a contributor. About 24% of comments discussed lack of awareness about the appropriate steps to take to prevent a suicide, or where to access the appropriate bereavement support. So, you know, there's quite a bit of discussion in the research that said that healthcare services needed to be more culturally appropriate. I also wanted to just share a couple of the quotes. I mean, there was a lot of research that came from this. So, and we weren't able to obviously provide all the quotes in the report just for people's safety and self-care. So, I guess as a member exclusive forum, we can provide some of the quotes that we didn't necessarily include in the report. So, one of the really resonating ones was this one. Being Aboriginal, I'm surrounded by death, but a significant amount of deaths are from suicide. There is an overwhelming feeling of helplessness and grief, but there is also this anger. Indigenous communities are the most affected by suicide and nobody else cares enough to do anything about it. That was from a 23-year-old Aboriginal man from a rural area who had lost 2 cousins to suicide within 2 weeks of another. We also did some analysis looking at self-attempts, the self-attempt survivors, from a sample of, as you heard from Myf, over 3,200 people. 75 people nominated exposure to suicide attempt as being their own. While the open-ended responses were quite limited with this group, there was quite a bit of dissatisfaction that was expressed with the health and support services when they were accessed, but there was also satisfaction when discussing complex care arrangements. So that includes, you know, care provided by GPs, psychotherapists, psychiatrists. 8% of people reported still feeling suicidal, while 16% said that they no longer felt this way and that their life was worth living. And interestingly, 4 people explained how they did not have the right words to be able to tell people about what was going on for them when they were suicidal to be able to express their need for support. 7 people also tried to get help for themselves or explain their suicidality and did not feel they were being heard. And 8 people reported empathy for those who had subsequently died by suicide who were known to them. So, again, there were a couple of quotes that really resonated with me in this research, which I think sort of demonstrate a lot of resilience and stories of hope as well. So this quote here really talks to the impact that suicide has on the individual. So, I am a suicide survivor myself and have felt my risk of suicide increase significantly following each suicide of a friend or loved one. That was an Aboriginal person who had lost 4 people to suicide. This one talks about the positive side of what people feel that they can do to act after going through a suicide in their immediate circle. I have attempted suicide myself, but was lucky enough to survive, but I have lost my brother, cousins, and many friends to suicide. I found that great family support and counselling for 5 years was my greatest support. I hope to one day help a family member or friend be a survivor too. And finally, this quote was quite an impactful one as well. So it really speaks to the benefit of having access to treatment and hospitalisation and medications at the time that they were needed. So due to the significant and devastating effect it had on me as a 15-year-old, I went into major depression and had suicidal thoughts daily, with quite a few attempts on my own life. Treatment, hospitalisation and medications were given, but it wasn't until I was put in touch with support from an organisation I was able to then freely express, talk about and work through my issues. I would not be here without such support. And that was a 45-year-old woman who had lost her brother to suicide 30 years ago. So as you can see through the qualitative research, there's a lot of information coming out there that was volunteered by respondents. There's a lot more that I think we can learn from this group of people who have found strength and resilience from their experiences. I think it's really important to also note that there were a lot of stories of hope within the research as well. So yeah, certainly an area that we can continue to work through and find more information from those who have emerged from a lived experience.
Thanks, Michelle. In terms of the themes that came out of the research, and as well as the analysis of the data, we suggested 6 recommendations in this report, and I think what that means for us is some of the work that we're all already doing and some of the things that we advocate for, and particularly in the recent election commitments, are consistent with some of these recommendations and findings, but there are some things that we need to shout louder about, we need to all get behind. So I'll just run through the recommendations that have come out of this report. So the first one is around increasing community awareness about suicide prevention and educating communities on suicide and the broad spectrum of suicidal behaviours to help build capacity within community to give and get help. Now, many of our members, such as yourselves, do a lot of work in this area already, but I think it's so important for us to continue that work and under this recommendation promote each other's programs and lessons and research and evidence-based resources to help build that community capacity. We saw this week with Are You OK Day that there is a great level of community awareness and increasing awareness of the importance of asking the question, but we need to help both articulate what needs to happen when people say they're not okay. So how can we build those conversations and educate people on the support structures around them, but also educating people on the broad spectrum of suicidal behaviours and understanding those, as we did from the research, the many unique experiences that people have, and the fact that many people with thoughts of suicide and suicidal behaviour, it's an ongoing management of this. So I think a lot of education around the spectrum of those behaviours. So we all have a role in that, both in running the programs that you already do, but also keeping that at front of mind as a group. The second is recognise the lived experience of suicide as a public health issue of significance in Australia. So we've seen from the research the level of impact, the ripple effect of suicide. We've seen the high levels of distress. We've seen that people are impacted by their experience with suicide over a long period of time. So we need to recognise that all these people touched by suicide, supporting these people and focusing on their health and well-being is a matter of public health for this country. So we need to take it beyond thinking about supporting people in crisis and look at every single person touched by suicide, who we now know is many of us, is supported, and that their experience, our experience, is recognised as a public health issue of significance. The third recommendation is to develop and support a national suicide prevention strategy, including a dedicated component addressing the long-term exposure and impact of suicide. So we've talked a lot about this over the past couple of years, particularly in the last 12 months, in terms of mental health and suicide prevention reform and how important it is to have regional infrastructures supported by national infrastructure. So we're all passionate about supporting primary health networks to deliver community-driven suicide prevention, but we need to have consistency, alignment, and national accountability and leadership. So part of that could be the introduction of a national office for suicide prevention. As we all know, it's not just about mental illness. We need to look at the social determinants of health, and we need to make sure that the work that we're doing cross-department is coordinated, and a national office can help to do that. We've also advocated for introduction of legislation, Suicide Prevention Act, which is essential to suicide prevention remaining a key national public health issue, regardless of the political landscape. So there's quite a few things that we can do to develop and strengthen the infrastructure so that all of these people exposed to suicide and impacted by suicide are supported. The fourth priority, and MIF reiterated again what we know is a huge problem for our Aboriginal and Torres Strait Islander communities, is to prioritise their suicide prevention for these communities and introduce culturally appropriate suicide prevention strategies. And we will continue to advocate for the immediate release of implementation funds following the suicide prevention strategy following the Aboriginal and Torres Strait Islander suicide prevention evaluation project. Also, as part of that recommendation, we mentioned culturally appropriate interventions. We need that to go across all cultures and communities. So it comes out very strongly, particularly in what Michelle was saying about the open text comments in the themes about all the different populations, communities, groups that identify as a specific cultural group really need appropriate suicide prevention strategies and communications for their communities. So working with diverse groups to make sure that it's culturally safe and appropriate. The fifth recommendation is to ensure consistent comprehensive discharge plans are developed and implemented for all patients upon being discharged from the health system, including the involvement of family, close contacts and community services. Now, we know at SPA this comes out loud and clear in our lived experience network, and it absolutely was reinforced in the survey itself in this research. And we are working with international partners and local experts on the Zero Suicides in Healthcare initiative, and there will be an international meeting in February next year to really look at what Australian implementation looks like. There's also a lot of other suicide prevention programs and initiatives from within the sector that are focusing on closing the gaps in healthcare and bringing in the family, whoever's identified as close contacts and community. So that's a big priority for us and for the sector. The final one is to engage the Productivity Commission to conduct a detailed independent assessment of the cost of suicidal behaviour in Australia. So this should include the costs associated with exposure to and impact of suicidal behaviour, as well as suicide deaths. And there's been some great work by people like our members, like Mates in Construction, who've done some cost assessments, but we really need to take this to a national level and conduct an assessment of these costs. So these are the headline recommendations. As I mentioned, there's a lot of work that Suicide Prevention Australia is already progressing on a number of these, as well as the work that our members and colleagues in the suicide prevention sector are undertaking. But I think these recommendations and communicating them beyond where we all work is important, that we make sure that we speak with one voice about the changes that we want to see and the implications of this research. So what we'd like to do, we've allowed quite a bit of time for questions, and we've already had a couple come through. Thank you very much. The chat box down the bottom, please do add in any comments you like. Of course, MIF and the Suicide Prevention Australia staff are always available for member questions and conversations. So anytime next week, if you are looking through the report and you have more questions, get in touch and we can either have some one-on-one discussions or set up another group briefing if that's helpful. So the first question for MIF, probably most questions for MIF, thanks MIF, is how does this research compare with international research?
Yeah, so I guess it's an important question because we've been building this evidence base across the globe now to understand exposure and impact of suicide as a public health issue, and I think that's important to quantify, but at the same time we also need to recognise the hope and resilience of people. So I just wanted to reiterate that first. In terms of international research, I've been working quite closely with Associate Professor Julie Serrell at the University of Kentucky, and there we were able to conduct a representative sample survey using a slightly different methodology but many of the same questions, and that's at the moment really the only other solid research that we have. Because that was representative, we were able to then go on through fairly complex statistical analyses to look at the number of people in the state of Kentucky that might be affected by each suicide death. And those of you who were at the SPA conference will have heard Julie talk about this, and that from that research we've been able to show that 135 people are exposed to each suicide death. It's important that we do quantify that to be able to demonstrate the public health issue that we're talking about in terms of exposure and impact to suicide, but then it's important to move beyond that too. So the next steps really now are to, both internationally and here, are to start to look at who is going to experience a long-term negative impact from being exposed to a suicide attempt or death, and at what point in time and what sort of support are best to be provided to those people. We won't be able to easily identify those people either, and that's what this research, as well as the research internationally, has shown, that it's not just the immediate kin and the immediate friends. So we need other ways to be able to identify a broader population who will be exposed to suicide. And some of the places that we might think about are workplaces, sporting clubs, any place where people are coming together and have relationships that might not be deemed as kinship or close friends, where that impact is still going to be felt. So we need to be able to now start to work out a way of proactively identifying people who may experience distress following on from exposure to a suicide attempt or death, what sorts of support they need and when it's best to intervene and to provide those supports.
Great, thanks Miff. Another really good question here. Someone is interested in the impact of suicide on practitioners working with suicidal clients, particularly the taboo around practitioners acknowledging lived experience. So what sort of insights did you find in the research in relation to that?
Yeah, so it's a really important point. It's a great question, and we did have people who have answered this survey from their experience as a health worker, as a counsellor, and that's an area that we want to do some more analyses now, because it's an area that we haven't thought a lot about. There is definitely a stigma associated with losing a client to suicide. And so we do need to work out ways both to support the practitioner as well as having some good support, some good ways in which they can then talk about what assistance they may need. And certainly in the States there's actually quite a good grouping of practitioners there who work in this particular area. And I think it's an area we could certainly develop in Australia to help support people who are at the front line doing their very best to prevent suicide. And Michelle might have some more to say in relation to that from the qualitative responses.
Yes, absolutely. From the qualitative research, there was a lot of commentary from people working in health professions who had experienced suicide either from their clients or people in their immediate families or social networks. So it definitely is a population group of interest. We certainly couldn't provide too much detail, obviously, in this report because it is very top line, but it's definitely an area that we are keen to develop further, particularly as it relates to the sector. I've just forgotten what I was going to say.
I think what was interesting too is what we had a conversation about on that. People who don't necessarily have working in suicide prevention or health in their job description, but they are exposed in their workplace. So I know when we were having that conversation, Michelle, that there were quite a few sort of unexpected professions, or that we may think are expected but don't have that support wrapped around them for suicide exposure.
Yeah, that's right. So I think to that point, Kim, we definitely, when we're looking at bereavement, I think a lot of the time we need to do more to learn about the people that we don't traditionally look at in terms of providing that care and support. So people who are exposed to suicides in the health profession are certainly an area that needs further support, and to provide them with what they need to do their jobs as well as carers.
Yep. And on the data front, Myf, obviously we can't publish everything in a report, but what other data is there, and what other opportunities do you think we have to learn from that?
Yeah, it's a great question. There's a lot more data than we thought there was going to be. I must admit that when Sue Murray and I spoke about this early on, I was thinking it'd be great if we get like 500 people, and that will be awesome for Australia. So the amount of data that's still there's a lot of analyses that we can still run in relation to what Michelle was just saying around those other work exposures is definitely an area that we'll look at in more detail. Certainly around the qualitative responses, there's a lot more that we can do there, as well as some of the more, the deeper analyses in the quantitative data. So looking at, for example, as I said earlier, the length of time from the death. We had people who had been up to 58 years since the death. So what that says is that there's still over a whole lifetime and an impact of this event in people's lives. But at what points in time are there that things may change? So just in the top level analyses that we've already done that we weren't able to put in the report, but we'll be working further on, around the 5-year mark something changes for a lot of people, and we don't know what that is. So what we'll do there is to go back and look at who is experiencing less distress at 5 years, and have a look at their qualitative responses as well as their responses across the whole survey, and try to understand a bit more about what's going on there. As well, for people that are experiencing a high level of distress over a very long period of time, looking at them as well and trying to understand a little bit more about what's going on in their life. Certainly in terms of the Aboriginal and Torres Strait Islander sample, we'll do more analyses there. I think it's really important that we do utilise these people who have so generously given us this information to really keep pushing to change the way in which we address suicide prevention amongst our Indigenous peoples. The 75 people who reported on their own suicide attempt also, we'll obviously look at them in much more detail to be able to understand more. One of the things that we haven't done very well is really look at the people who are most intimately affected by suicide in terms of our prevention activities, and this is giving us a real opportunity to do that. Michelle touched lightly on the people that had reported on their own attempt, and I think it's important to highlight just one part of that, which is that people say that they didn't have the right words to use. So at the time of their suicide attempt, they knew what was going on internally, but they didn't know how to express it, and so we have a lot of pressure on people to be able to talk about what's going on for them, at the same time as people saying, I don't know how to say what's going on. So part of that is about stigma, absolutely, but part of it is also encouraging all of us, just as community members as well as people working in the sector or associated with the sector, to really go beyond asking just, are you okay, which is a great starting point, but then to also question a bit deeper. And I think it's all of us will have heard people say things like, "You're not thinking of doing anything silly, are you?" Well, that doesn't ever help somebody open up if they don't have the words to talk about what's going on anyway. So I think encouraging that deeper level of conversation is what's coming out from these findings, and certainly something that we can keep exploring within this data.
We've also had some questions about perceived closeness, and I know as a communications professional I found that quite interesting, thinking about the people that said in the survey that they were close to someone but may not have had access to the services, or may not have been immediate family or in their school or in a specific group that received support, and how you actually respond or target those people with prevention or support messages when you don't know who they are, but they have perceived closeness to someone.
Yeah, it's a fascinating area, and this has come from, again, my collaboration with Julie Serrell. When we were analysing data several years ago, I think in 2011, we were trying to work out what this was, because it wasn't about kinship. And that's when we started including in all of our work these questions about perceived closeness. And it's a really interesting concept, because it also helps us a little bit understand some of the other ways in which suicide affects communities. So an example of that is when Robin Williams died, and across the globe people felt affected by that death, and so most people who felt that would never have met him and didn't have a relationship that you could identify as kin or non-kin. But if you identify with somebody because they're in some way similar to you, then that closeness of the relationship doesn't actually have anything to do with your kinship to them or a technical friendship to them. Another example comes from one of my PhD graduates who looked at young people and their experience of suicide exposure, and an example from one of those young people at the time of the death was that they had caught the same school bus with this person every day of their life. They didn't even go to the same school. They knew each other by name. They were friends on Facebook, like many young people, thousands of friends on Facebook. But they weren't technically friends. But that exposure to that suicide death was huge for this young person. And because they were at another school, they wouldn't have even been seen as being part of somebody who may need support. And so that's where it's really important to start to look at, in a community, and say a rural community like that, there's many relationships that aren't identifiable, and so it's definitely a challenge for the sector in terms of thinking about ways of responding when a suicide death does occur, and particularly much more broadly. And I think if we're just starting from the point that every single person in our community may at some point be exposed to suicide attempt or death, then we're probably starting from the right place.
Okay. Another question here, did we have any particular learnings coming out of this research on peer-to-peer support, particularly in regional areas?
So we didn't specifically ask about peer support, and in fact, I guess one of the issues with designing a survey is that you can't capture everything. We were very thoughtful about trying to make this a relatively quick survey so that people did engage with it and did complete the whole survey. So when we were asking about support services, it was particularly around healthcare support as opposed to peer-to-peer support. However, that being said, we know that there is some good models for peer support, and it's certainly an area that is quickly developing and should have the recognition that it deserves in terms of success. And that is around some of the things, some of the quotes that we heard, where people find when they are talking to peers who have had the same experience that there is already an empathy for what has happened. And we know that through, for example, suicide bereavement support groups have been one of the longest term ways in which people have found help. But we also know that doesn't work for everybody. So we certainly need to have a broad smorgasbord of services and support. But we also need to start working on evaluating some of those peer-to-peer support organisations and individuals, so that we can say, here's a way in which is a valuable service delivery option for people, and it does deserve the recognition that it does work for many people.
Another question from a member here is if there is any data or specific comments in relation to one of our member organisations, can they have access to those comments or data to inform their services and improvements?
So we didn't actually ask for specific information about support services, and Michelle will be able to answer whether there's anything that's come up in the qualitative data specifically about services. But often people were much more generic than that, and that's because of the way we designed the survey, obviously, which will always have its limitations. What I think is really of probably more benefit is that in the open-ended responses, which we've been talking about as qualitative research in this webinar, that's where people were really just able to say, is there anything more you'd like to tell us? And there was some amazing amounts of data that was included there. So I think the more generic is actually probably better at this particular point in time. From the data I've looked at, I haven't seen anything that specifically identifies any service, and certainly we weren't aiming to do that, but to look much more broadly at responses across Australia. I think it is a really good point, though, for any services to think about the way they collect and use the data that they're collecting. In my work, obviously, as a researcher, I think about evaluation a lot, and what I know is that most services are only reporting back what they're asked by their funding bodies to do. What that means is that there's actually a whole lot of data that's not getting used, or it may be getting used in ways that we're not really learning from. And over time, we must work with what we have, as well as embedding really good research into the normal routine data collection that happens. And I know some of the organisations that members who are listening right now are working on that and doing that, and I really encourage everybody to keep working with that, find research partners to be able to develop a much broader research base in suicide prevention activities in Australia.
Great. Michelle, did you have anything to add from the open text comments?
Yeah, so just with the qualitative stuff, I suppose to answer that question about the naming of services, there was actually a little bit from people talking about services that worked for them and some that didn't. So there was a bit of mention, not a huge amount. There was a lot of discussion about informal support, informal care and supports, or inappropriate knowledge of how to provide informal care. So I think there are certainly themes that came out that have been really interesting, and areas that we need to look further into, but were unable to for this particular report. But yeah, we can certainly try and share some of the insights that we gained from.
I know there are thousands and thousands
there are
of results, but yeah, I think it'd be useful to have a look, and we can see certainly if any particular services are named, we can have a look at that. But as Michelle was saying, it's important to, as thinking about any one of our members who are service suppliers, to think about that feedback in the themes on either mental health literacy and an understanding of what services are available, as well as how people are accessing or otherwise the services. So thinking about those two issues, which I know is always front of mind for many of us. We've got time for a couple more questions if anyone wants to add one into the box. Otherwise, I just wanted to say a big thank you to everyone for getting behind sharing of this survey. It is just such valuable information that is equal parts heart-wrenching and inspiring. And what it says to us is it really reinforces just how valuable the voice of lived experience is in everything that we do. And there's a lot that we can learn from what we've analysed so far, but also future opportunities for work. So we will definitely pull in members to have a think about what else we want to learn from this data, and get people involved depending on which subsection of data we want to look at next. So again, if you have any extra questions or you want to talk through this in more detail, we're always available. Give the SPA office a call, or get in touch with myself or Michelle directly if you'd like to. One more question that's come through on social media. So always an interesting one about the sort of benefits and challenges of social media when you're trying to support people impacted by suicide. Mif, maybe you could have a talk to that sort of issue.
Yeah, so again, we didn't specifically ask about social media, but we do know that obviously information is shared very quickly, and that sometimes that may not be particularly helpful at the point in time. And I guess in thinking more broadly about this particular issue, given that in our survey we didn't necessarily talk about the impact of social media, we do know from work that I did with the Hunter Institute for Mental Health a few years ago that people who have been bereaved by suicide do find just general media about suicide distressing, and it does impact upon them. So we do need to think about that kind of messaging beyond just the traditional news media, and even into a lot of the just popular TV shows now, whether they be crime shows or they're often based on murder or suicide, and we're thinking about the way in which those all of that constant reminding of people of events that have passed will have an effect on people. So we do need to consider certainly the way in which, obviously, the way in which we report on suicide generally, whether it be in research or whether it be through social media, and obviously the Mindframe guidelines are world renowned for providing good guidance on that. But I think social media doesn't necessarily come under some of that, because it is generated quickly, and so I guess encouraging people to be thoughtful about how their messaging going out into that very public realm may have an impact on people who have been exposed or impacted by suicide.
There's some good communications lessons to be learned from the analysis of the perceived closeness as well, I think, is that always assume that there are other people who are watching or reading or absorbing while the information that you post on social media. So as we're communicating something about a suicide prevention initiative or some support or service, is I think always assume we're talking to so many more people than we're actually meaning to engage with on social media, and thinking about how we can do that in relation to those sort of not easily identifiable close people. So we've only got a few minutes left, so I think that might be our final question for now on the chat. I just wanted to say thank you so much to everyone for joining us today. As I mentioned, we talk a lot about data and numbers, but we acknowledge that every single one of these people who's contributed is talking about very personal lives and connections. So we very much appreciate the lessons that we've learned from the personal experiences that they've shared, and really look forward to doing that justice in terms of how we use that data and how we learn from it, and make the work that we do better for everyone involved. So thank you very much. We'll be making this webinar available on demand for members who couldn't make it along today, as well as members of our Lived Experience Network next week. So thank you again, and the report will be available from midnight tonight online. You've obviously got a preview of it here, but as your teams already know, we really appreciate your assistance in getting this information out there and promoting the services and support that many of you offer to help us prevent suicide in Australia. Thank you very much.